everyone. I'm Deep Parikh. Welcome to the Zeiss Ophthalmic Medical Education Summit. I'm Adjunct Assistant Professor of Retina and Uveitis at New York Eye and Ear Infirmary of Mount Sinai and Adjunct Assistant Professor at NYU Langone, Long Island School of Medicine. I'll be moderating today's session on retinal disease management from routine to extreme. Here joining me today is our esteemed faculty panel, Dr. Sarah Gleason and Dr. Carolyn Major. And I'll turn it over to Dr. Sarah Gleason to go ahead and introduce yourself.
Thanks, Dr. Parikh, for that introduction. So my name is Sarah Gleason, and I practice in New York City. I'm assistant clinical professor at SUNY College of Optometry, and my main areas of interest include glaucoma and retina. We'll be getting into a lot of retina today. So I'll pass it over to Dr. Major next.
Again, such a pleasure to be here and welcome everyone. I'm Dr. Carolyn Major. I'm an associate professor and the director of residency programs at the Oklahoma College of Optometry. And I do pretty much any sort of disease. My real forte, I think, is retinal disease, but glaucoma, neuro-ophthalmic disease, systemic disease, I love it all. A pleasure to be here today. Looking forward to this discussion.
So welcome again, everyone. I'm really looking forward talking to you about interesting retinal cases this evening. Specifically, I'm going to be talking about the role of OCT angiography in managing our diabetic cases. So both routine cases and extreme cases related to diabetic retinopathy. So we'll start off with the case presentation. We have a 61-year-old female presenting for a doctor-directed follow-up. Now she's managed in our clinic for both glaucoma suspicion and diabetic retinopathy, but we're going to be focusing just on her diabetic history and imaging today. So she has type 2 diabetes, a fasting blood sugar of 110, and an A1C of 8.5. She reports moderate control and that she's taking 2 medications, and her BCVA is 20/20 in both eyes. Her anterior segment exam was unremarkable, so we'll jump right ahead to her posterior segment imaging. So here we have her color fundus photos. And you guys can see here that she has some retinopathy going on. This wasn't the first time she presented with retinopathy, but it looked a little bit worse at this particular visit. So if you take a look, she does have some microaneurysms, most significantly temporal to the macula in both eyes. And she also has some retinal hemorrhages, evident superiorly, and some areas of exudation as well. So sometimes I like to do red-free photographs in these cases, especially if the retinopathy is a little more subtle or if the exposure wasn't just right on the color photos, because it really highlights those areas of hemorrhages even more and the areas of exudation as well. And you see that highlighted here in the red-free images. So we didn't perform OCT at this particular exam. We brought her back 3 months later to do so, and we have her MAC cube posted here. So as you guys can see, in that 3-month period, she actually developed some macular edema. So she has an area of retinal thickening superior to her macula in the right eye. She actually has a trail of exudates moving inferiorly, affecting the central macula as well. And we also took an OCT angiography at this visit. Now, it was interesting to go back through this case because this must have been one of the first patients we imaged at SUNY with an OCTA, because it was right around the time where we actually obtained the ability to do this testing. And at the time, we didn't know so much what we were looking at, and it's just amazing to think about how much more we've learned about this technology over the years. So what I've pulled here is her superficial capillary plexus at the top of the slide and the deep capillary plexus at the bottom of the slide. Of note, we actually can see that large retinal hemorrhage with the shadow here and that area of exudation inferiorly. What I'd like to focus on is the foveal avascular zone. And as we can see in the left eye, it looks a little bit smaller than it does in the right eye. And in both, it's actually a bit enlarged. And this we know is a hallmark of diabetic retinopathy. We get an enlargement of the foveal avascular zone. And this is seen more significantly in the patient's left eye.
These are beautiful images, Sarah. And I want to point out, if you're dealing with like interretinal disease, like diabetic retinopathy, vein occlusions, you want to focus on those superficial and deep capillary plexus preset and FOS displays, exactly like you've put forth here for us. So thank you.
Absolutely.
Sarah, quick question. Are you routinely getting OCTs, OCTA, but also just regular OCTs on your mild NPDR patients and moderate ones, or are you sort of waiting till, they become more severe in retinopathy?
So years ago, I kind of was waiting. I didn't always think it was necessary if I wasn't seeing much retinopathy, especially in the area of the macula, to obtain these images. But now that we have the ability to do OCTA, even if there aren't hemorrhages or exudates present centrally, I really like to get a regular OCTA and then specifically, or a regular OCT and specifically an OCTA to look for this area of ischemia.
Yeah, I completely agree. And that's exactly what I do too. Even if they're early NPDR, I think your pictures here, this OCTA of the left eye really highlights why it's important to get that. So I'll let you continue, but I'm on the same page here.
Thank you. Okay, so we diagnosed this patient at this time with moderate non-proliferative diabetic retinopathy in both eyes and macular edema present in the right eye. And we now know that she had this significant area of macular ischemia more evident in the left eye compared to the right eye. So our plan at this time was to, of course, educate our patient on the importance of improved control and also refer to a retinal specialist to evaluate that macular edema for possible treatment. Despite the fact that she was 20/20, it was central, and consider a fluorescein angiography due to that documented ischemia in her retina. So unfortunately, this patient was lost to follow-up. We did see her finally 3 years later. At this time, she was 64 years old. She presented still with her diabetic history, except this time the picture looked a little bit different. So her A1C was 12. Her fasting blood sugar was consistently elevated. She was on a third medication, and she knew that she was not well controlled at the time. This was at the height of the pandemic in New York City. She was working from home. She was not exercising. She was not eating healthy. And she was aware that she had kind of let things slip. So she came in for an eye exam. So again, we have our color photos here. And you guys can see that this case has kind of escalated from a routine case to now an extreme presentation because she has proliferative disease. So if we look at the right eye, she has an area of pretty significant neovascularization of the right nerve. And if we look at the left eye, she has a very large area of neovascularization of her retina here. And of course, we see more hemorrhages and exudation as well. Again, we have those red-free photos, which tell the same story, but just give you a little bit of a different perspective and maybe highlight those areas a little bit better. And we have a close-up picture of the nerve. And you can see here just how many neovascular blood vessels are present over that right disc. So we repeated her OCT at the same visit, and luckily it seemed that that edema that was present 3 years ago since resolved, and for the patient, she did not have any history of reduced vision in that right eye or either eye over the last few years, but her OCT angiography will tell a different story, because we actually see an enlargement of the foveal avascular zone compared to her original exam. I do have a side-by-side comparison in a few slides, but for now, this is all from that visit. And again, we have those superficial layers on the top, the deep layers on the bottom. And you guys can see now that just overall, it looks darker, it looks less saturated with capillaries, and there's more areas of capillary dropout, both within the fovea and paramacularly as well.
It's sad, Sarah, we see a lot of these cases where because of the pandemic and because of all the same things you alluded to, now we see this extreme pathology that without the pandemic, we would have caught this, she would have had a 3-month follow-up and she would have started treatment sooner and she wouldn't have this sort of late stage diabetic retinopathy. And it's kind of sad, and it's sort of an overlooked problem that the pandemic sort of caused. Are you seeing a lot of these type of patients that have sort of been lost to follow-up and now are presenting with just tons of pathology?
Unfortunately, I have, especially being in New York. I think so many patients were so hesitant to come in during the height. And then, even still, I get patients that are really hesitant to ride the subway, go on public transportation. And unfortunately, I've had to deliver more bad news during and post-pandemic than I was pre-pandemic. And it's just so sad, especially in conditions where the acuity remains 20/20, but the patient is unaware about what's going on. You can't even fault them for wanting to stay healthy. But unfortunately, these things go undetected and untreated.
Good point.
Yeah, we've also seen a lot of cases in our clinic of like bilateral vitreous hemorrhages, tractional retinal detachments after the pandemic finally lifted and we were able to see these patients again. I agree. I think this is a great case because she still is 20/20. So this is an opportunity for you to get in there and intervene, and you're able to keep her good vision versus somebody who comes with like a MAC off tractional retinal detachment. It's hard to get that vision back.
Absolutely. At least we caught it in this case before that happened. So I'll move on to the next angiography slide. So anytime I'm suspicious for neovascularization of the disc or I see it in my clinical exam, I always obtain an angiography over the nerve as well. And I have that listed for you guys here. Just a quick note of the left nerve. This is a little bit of a segmentation error here, so that's why it doesn't look completely round. But in this particular slice of the OCTA, you want the nerve to look black. You don't want to see any blood vessels on top of the nerve here. And the right nerve, you can just really see how many blood vessels are there and how significant that neovascularization is. If you look at the bottom of the slide, we have our tomograms, and this indicates areas of red, which indicate areas of blood flow. So remember, our OCTA is taking multiple B scans over and over again and looking for movement in the retina, and that movement is going to be blood flow. So you can even see within this neovascular net, over top of the optic nerve, she has blood flow. So this is just a great image of what's going on both on FOS and a tomogram through that area of proliferation.
I think even without OCT angiography, let's say you're in a practice that you don't have it, if you're doing just structural raster scans through the optic nerve, you have that classic presentation of neovascularization on the disc, where I like to call it like a hammock hanging across the cup, or that pre-retinal tissue. Because sometimes in patients that have, bad cataracts or poor fixation, nystagmus, I'll just kind of use a raster scan to like look around the posterior pole or kind of scan across the nerve, looking for areas of tissue sticking up out of the retina that may signify pre-retinal neovascularization, or as in your case here, neovascularization of the disc.
Absolutely. And that's a great point, because not everybody has OCTA capabilities now, but if you have OCT capabilities, you can still use those tools to pick up that neovascularization. So in this patient, unfortunately, the OCTA did not capture that area of retinal neovascularization, but I did pull an image just to show you guys what that would look like. So this is showing that area, an area of retinal neovascularization. And just as was just said, we know that this blood vessel should not be growing on top of the retina. So you don't even need it to say that there's blood flow in the area. If you see a vessel that looks anomalous and you do an OCT through the area, you can really document that neovascularization quite well.
Dr. Parikh, I'm curious to have your input on that. Is it unusual to see patients that have neovascularization within that macular scan? I feel like a lot of the patients I'm seeing who are type 2 diabetics, a lot of the neovascularization is kind of like in the arcades or like out towards the mid periphery. What's your experience?
Yeah, absolutely. And a lot of it just, there's you're going to get a lot of variation in people's presentation, but I definitely agree with you. I mean, a lot of the neovascularization you're going to see is going to be in areas sort of in between ischemic retina and vascularized retina. So it'll be in the arcades and the periphery. And oftentimes you'll see NVD first and, or at the same time. But, there can be various presentations, and I bet there's in that patient in their left eye, I bet there's neovascularization elsewhere. If we look farther in the periphery, I bet there's other areas also involved. But yeah, I also did think that was interesting.
That's a great point.
The other one thing I did want to mention is, as we all know, these eyes, this is at such high risk given the level of pathology that these eyes can go south really quickly. I know, this patient's 20/20 right now, but, and I'm glad she finally got in and saw you, Dr. Gleason, because like, this is the type of thing where like, if she had gone another 6 months, who knows, she may have come in with that MAC off TRD, so I think it's key just getting her in.
Okay, so our plan for this patient. So she was diagnosed with proliferative diabetic retinopathy in both eyes. And of course, we have that area of macular ischemia more significant in the left eye. Our plan was to refer to our retinal specialist for treatment, and he opted to perform PRP in both eyes for this patient. So just an overview of diabetic retinopathy. We know this is something that we see all the time in the clinic, but it's always nice to just take a step back and remember what's going on in the retina in our patients. So we have our non-proliferative disease, and this is characterized by increased vascular permeability In more mild stages, we'll see microaneurysms. As the disease progresses, we'll see more hemorrhages and exudates. And as severity increases further, we'll see cotton wool spots, ERMA, venous beading. In proliferative disease, we have persistent retinal ischemia, which leads to release of VEGF, which leads to angiogenesis. And this leads to development of NVD and NVE, as we saw in the case. Complications of this can include vitreous hemorrhage, tractional retinal detachments, all the things we want to prevent in our patients. Of course, we have diabetic macular edema. We're very familiar with this as it's the most common cause for reduced acuity in our patient. But in this case, we have a breakdown of the blood retinal barrier, and this leads to intraretinal accumulation of fluid. In our patient, this didn't end up being something so significant that we were dealing with, but we see this very frequently. And we also have diabetic macular ischemia. So this is something that we don't think about or talk about anywhere near as frequently. However, it's something that's occurring in our patients, and we know that the retina is ischemic. That's why we worry about proliferation. And this is characterized by capillary occlusion and atrophy. However, you will not document this in your patients if you're not performing angiography. So previously, we weren't going to refer our mild patients to get a fluorescein angiography since it's a quite invasive procedure if it wasn't really indicated. However, with the advent of OCTA, we can actually document this on our patients very early on in the disease process. So again, I pulled up the patient's left eye, the areas of macular ischemia compared between that visit 3 years prior and the visit 3 years later. So if you guys can notice, she has a just overall reduction in capillaries. It looks just a little bit dimmer, a little bit less saturated on the right side of the slide. And you can appreciate how the foveal avascular zone is widened, and she has these areas paramacularly of that capillary dropout documented. So diabetic macular ischemia, we know that this occurs when there's capillary occlusion and atrophy. And as with our patient, visual function generally is not affected unless the ischemia is very, very severe. We do know that there is a correlation of severity of ischemia with the severity of the retinopathy, and therefore it can be an indicator of a risk of progression to proliferative disease. So there's many studies on this topic. I just pulled one that was published by Sheng Yu et al. In 2020, and this just confirms all of those things. So we know that if there's macular ischemia present, the patient may be more likely to progress to proliferative disease, and that we should consider earlier referral and more frequent follow-up schedule. And this is a figure from that study. The areas of blue are showing areas of capillary dropout, and you guys can see that that capillary dropout significantly increases with the severity of the disease.
Yeah, I feel like figures just like this have been published like over and over and over and over. Yeah, so I think this is a really well-known, well-established fact right now that the retinal ischemia increases with the severity of the disease.
Absolutely. So just some clinical pearls to wrap up this case. I always like to think at the end of every conclusion of every case is what is our goal of doing these clinical exams? And it's really to preserve vision. So every time we're examining our diabetic patients, we're trying to determine what is the risk of vision loss in this patient's lifetime. When do we need to see the patient back to ensure that we catch it if there is going to be vision loss, and when is treatment indicated? We now know, as we just went over, that diabetic macular ischemia is something that we should be looking for. If you have the ability to run OCTA on your diabetic patients, I recommend running it on all of them, regardless of level of retinopathy, because we know that it can be useful in determining how frequently you want to see that patient back, and it will help us better take care of our patients and hopefully better preserve vision for all of these patients that we see. And I think that's it. Do you guys have anything else to add about the case or the topic?
I thought that was fantastic, and I think your conclusion was great. And I just want to point off that one of the things you mentioned, where the patient doesn't really appreciate a decrease in vision until there's severe ischemia. And I just want to highlight that because, the whole point of getting this testing is to sort of twofold. One, it allows us to prognosticate, like you mentioned, Dr. Gleason, and prognosticate and see who we need to really follow closely. But I think secondly, if we can show these images to patients and they can see it with us, and we can just say, hey, this was your foveal avascular zone prior, look at it now, this is getting worse. I know you're not symptomatic from this, but if it gets even bigger, then we're going to have a problem that's really irreversible. And so I think, even for education purposes, for patient education, I think this is I think OCTA is a really useful tool here.
I couldn't agree more. I was actually going to mention the same thing. I think especially when you have a patient who still has 20/20 vision, I was going to ask you, Sarah, was it hard to convince this patient that they needed to go see retina? Or were they kind of like in denial that anything was going on with their eyes? And the images really help, I think, convince them, right?
Yeah, the images helped a lot in this case. I mean, there was something to be said, the fact that she came in during the height of the pandemic when we weren't even doing regular patient care because she was concerned. So it was helpful that she was kind of, aware of her diagnosis and aware that things could turn south. But being able to turn that computer screen around, show her the photos of the neovascularization, show her the change from the visit 3 years ago, and talk to her about what her risks were if we did not treat it. She luckily was very amenable to treatment and was much more compliant moving forward. All right, so I guess that wraps up my discussion on OCTA and diabetic retinopathy, and we will now move on to the next case discussion.